Welcome to the Deep Dive. We take complex medical topics, distill them down, and give you the essential insights you need. Today, we're going to focus on a really critical area of pediatric ophthalmology, high myopia in infants and young children. Our source for this deep dive is the comprehensive journal article, IMI Management and Investigation of High Myopia in Infants and Young Children. And this isn't just about prescribing glasses, is it? It's potentially about life-changing diagnoses for these very young patients. Our goal here is to pull out the most important nuggets of knowledge from this paper, helping you, our fellow eye doctors, navigate this rare but really significant condition. So let's start with something that might just open your eyes a bit. High myopia, defined as SINGA 6.0 diopters or worse, is actually remarkably rare in preschoolers. We're talking less than 1% prevalence globally.
That's right. And even in places with high overall myopia rates like China, it's still only around 0.03% to 0.2% in kids under 7.
So it's definitely not something you see every day. If you encounter it, it's already an unusual case.
Exactly. And what's truly critical to understand, and what this article really emphasizes, is that the etiology, the underlying cause, is fundamentally different in these young kids. It's different from the sort of typical progressive myopia we see starting in school-age children.
How so? Different in what way?
Well, it's often what the paper terms secondary myopia. This means there's usually a single specific underlying cause driving it. It's not typically the multifactorial picture we see later on.
Okay, that's a crucial distinction. So these secondary causes, what are the big ones we need to have on our radar? What makes early onset high myopia so unique?
The first major category is myopia of prematurity, or MOP.
MOP.
Yes. Premature infants, especially those who've had retinocular prematurity, RP, they're at a significantly higher risk. But the key insight here is that MOP isn't just high myopia. It's often a fundamentally different kind of myopia.
Different how?
It's largely lenticular. The study highlights some really crucial biometric differences. Kids with MOP often have steeper corneas, shallower anterior chambers, thicker lenses, but importantly, shorter axial lengths compared to full-term kids with similar high myopia.
Shorter axial lengths with high myopia, that sounds odd.
It does, doesn't it? But the paper gives an example. Highly myopic preemies with ROP had a mean refraction around 9.4D, but their mean axial length was only 23.36 millimeters. Now compare that to full-term highly myopic kids. Similar refraction, negative 11.7D, but their mean axial length was much longer, 27.02 millimeter.
So the power is coming from the lens, not the length of the eye.
Precisely. It's primarily a lenticular difference. And that really changes your thinking about management, right? Treatments aimed at slowing axial growth might not be the main strategy here.
That makes sense. Does the RP treatment itself matter?
It seems to. The study mentions cryotherapy led to more myopia than laser treatment, and bevacizumab seemed to have less impact than laser. Interestingly, the variation in refractive outcomes in these ROP-treated eyes wasn't even correlated with axial length.
Fascinating. So beyond prematurity, the study talks about monogenic myopia. That's where genetics really takes center stage.
Yes, this is where a single gene mutation can have a huge effect, and it requires a really comprehensive evaluation.
So what should we be looking for if we suspect a genetic component?
Well, these monogenic forms can be isolated, meaning high myopia is the main thing you see, or they can be syndromic. Syndromic means the myopia is part of a bigger picture with other ocular and even extraocular features.
And the chance of finding a genetic cause is higher with syndromic features.
Much higher. The paper quotes a diagnostic yield around 35% if syndromic features are present, compared to maybe 14% in isolated high myopia.
Okay, what kind of syndromes are we talking about?
Well, one important group is the inherited retinal dystrophies. High myopia can actually be the first sign you pick up. The article mentions genes like RPGR and RPE65, and RPE65 is particularly relevant now because there's an approved gene therapy for related conditions.
Wow, so early diagnosis is key there.
Absolutely. Other examples include blue cone monochromacy, and then there are metabolic disorders like gyrate atrophy from OAT deficiency or homocystinuria from CBS mutations. These are critical because dietary changes might actually help, and early diagnosis impacts vision, education, and can even prevent life-threatening systemic issues.
So it really underscores that we're looking at the whole child, not just their refractive error.
Right.
What about connective tissue disorders, things like Marfan?
Exactly. High myopia is a known feature there too. Stickler syndrome is a prime example, maybe 1 in 7,500 births. The paper describes these really characteristic vitreous anomalies, membranous or beaded, plus congenital myopia, which often, interestingly, Doesn't progress much.
But high risk for other things.
Definitely. High risk of retinal detachment, including giant retinal tears and congenital lamellar cataracts. And then you have the extraocular features, hearing loss, that mid-facial underdevelopment, sometimes part of Pierre-Robin sequence joint hypermobility,
Mm.
early arthritis. And the article mentions something called cryptomyopia, where megalophthalmos might be hidden by a flat cornea. So axial length measurement becomes absolutely vital.
Right. And Marfan syndrome.
Also important. About 1 in 5,000, due to FBN1 mutations, you get the classic ocular signs, lens dislocation, RD, glaucoma, cataracts, but also the skeletal features long limbs, scoliosis, and critically the cardiovascular involvement like aortic dilation. That's potentially life-threatening.
So diagnosis has huge implications for the family, too.
Huge. Family history is key, and diagnosis usually triggers referral for the whole family. The paper also mentions Ehlers-Danlos and the rarer Knobloch syndrome.
Okay, this really paints a picture. If you see high myopia in a very young child, your first thought shouldn't just be, let's get them glasses. It's more like, what else could be going on here?
Precisely. It's a paradigm shift. The refractive error might just be the tip of the iceberg.
So given that mindset, how do we actually approach the evaluation? How do we peer into these cases effectively? What's in the toolkit?
The absolute primary goal, as the article states, is to identify those syndromic forms with broader health implications. And your first, and arguably most powerful tool, is simply a detailed clinical history.
What specifically should we be asking about?
Family history is huge. Refractive status, yes, but also poor vision, even with glasses, any color vision issues, especially blue-yellow or Triton defects, poor night vision, history of retinal detachment surgery, especially if it was bilateral or involved giant tears.
Okay.
Also, familial deafness or cleft palate, think Stickler. History of heart valve surgery in the family, think Marfan or related disorders. And of course, the birth history prematurity is key. Plus, it's a simple check on developmental milestones. Delays are common.
Right. And beyond history, the physical exam, looking beyond the eyes.
Absolutely crucial. Don't just eye the eyes. Check psychomotor development. Look closely at facial features. Micrognathia, mid-facial hypoplasia, long philtrum, flattened nasal bridge. Subtle signs, often best seen from the side, that might point toward Stickler.
And screening for things like joint hypermobility.
Yes, very useful. A quick screen using the Baton score or just checking pinky hyperextension, thumb to forearm, elbow knee hyperextension, maybe skin elasticity. That can flag potential Ehlers-Danlos, Marfan, or Stickler. And don't forget to look inside the mouth, check the palate for clefting, a bifid uvula, or a high-arched palate.
That's a really comprehensive systemic check. Now, turning to the ocular exam itself, what are the red flags there?
Well, it starts with the basics done well. Age-appropriate visual acuity and cycloplegic refraction are essential. Reduced, best-corrected visual acuity, despite the refraction, is a major red flag. It strongly suggests underlying retinal disease.
What else?
Color vision testing, specifically looking for Triton defects with plates like the HRR. The presence of nystagmus, especially with high myopia, points strongly towards retinal dystrophy. Check pupillary reactions carefully. A paradoxical reaction can indicate conditions like congenital stationary night blindness, CSMB.
Okay, and the slit lamp exam.
Detailed anterior segment check. Cornea for signs of keratoconus,
Mm.
iris for transillumination defects suggesting albinism, check anterior chamber depth, look closely at the lens for microspherophycia or any signs of dislocation. Then, dilated exam focusing on the vitreous and retina. Look for those classic Stickler vitreous changes, membranous or beaded. Look for signs of inherited retinal disease or any sequelae from ROP treatment.
And intraocular pressure.
Absolutely critical, even in infants. You have to rule out congenital glaucoma.
You mentioned earlier that some of these causes aren't primarily axial. How important is ocular biometry then?
It's vital. Biometry is essential to figure out why the child is myopic. Is it truly axial elongation, or is it refractive, like from the cornea in keratoconus, or the lens in ROP? You need to measure axial length, keratometry, ideally corneal topography, anterior chamber depth, and lens thickness. These numbers are key for diagnosis and for monitoring later on.
And if things still aren't clear, or for specialist centers?
Then you move to advanced investigations. Ocular imaging, like wide-angle fundus photos, fundus autofluorescence, which is really useful in kids because pigmentary changes might be subtle early on, but autofluorescence changes can be present. OCT is also very helpful, looking at the ellipsoid zone for retinal dystrophies. And electrophysiology, especially full-field ERG, is essential if you suspect a retinal dystrophy, particularly with reduced BCVA or nystagmus.
And genetic testing.
Yes, if you suspect a monogenic or syndromic form, referral to clinical geneticists, genetic counselors, or pediatricians is crucial. Whole exome sequencing can often provide a rapid genetic diagnosis these days.
It really sounds like the primary eye care practitioner is the crucial first step, identifying these out-of-the-ordinary cases and knowing when to dig deeper or refer.
Absolutely. Even doing a targeted history and a quick screen for things like Jane hypermobility or checking that BCVA carefully,
Mhm.
that can make all the difference. You're essentially seeing through the simple myopia presentation.
You are. So once we have a clearer focus on the diagnosis, or at least the likely category, how do we approach the optical correction and overall management? This is where we directly impact their visual development, right?
It absolutely is, and it comes with its own challenges. Getting young children, especially infants, to wear glasses or contacts consistently can be tough. Compliance can be a real issue, particularly if there are associated neurobehavioral problems. And uncorrected high myopia, as the paper points out, can lead to profound amblyopia and severely impact visual development. They even mention the term visual autism for that kind of isolation.
That's a powerful term. Are there specific guidelines for when to correct?
Yes, the article references current guidelines recommending correction for bilateral myopia less than Menafide 5.0D in babies under 1 year, then less than Metaphor 4.0D from 1 up to 2 years, less than Menafide 0.0D from 2 up to 3, and less than Metis 2.5D from 3 up to 4 years.
So basically, all high myopes in this age group will typically need correction.
That's the implication. And the general recommendation is for full correction. The thinking is that these highly myopic eyes have already failed the emmetropization process. Undercorrection doesn't seem to offer any benefit and might just hinder functional vision and development.
What about the really tricky cases, like high anisomyopia, big difference between the eyes?
Yeah, that's particularly challenging because of anisoconia, the image size difference. It can be really disruptive. Contact lenses are often the preferred route there to minimize that difference compared to spectacles.
Does that impact progression?
Well, conventionally, standard contacts aren't thought to affect progression much. But the article does mention some case studies suggesting a possible benefit on progression in the more myopic eye with high anisomyopia, though more research is needed there.
And for the most difficult situations, non-compliance due to other issues.
For those really tough cases, severe isoemmetropia or anisomyopia in kids who just can't manage glasses or contacts due to neurobehavioral issues, intellectual disability, or craniofacial problems, surgical refractive correction might be considered. Things like excimer laser, clear lens extraction, or phakic IOLs. It's controversial, of course, but the study does cite evidence showing it can be effective in these specific scenarios.
Effective how?
They report significant gains in visual acuity, like a mean improvement of 1.6 lines in one series, without loss of BCVA. And interestingly, they even noted developmental improvements in some kids with intellectual disabilities once their vision was properly corrected surgically. It really highlights the impact of clear vision.
Okay, so getting the correction on is the first major step. But then the question that always comes up with myopia, what about progression? How do we manage that in this very specific, a very diverse group?
Yes. And this is where the article urges significant caution. It's a really crucial takeaway message.
Mm.
While there's obviously huge interest in active myopia management now, behavioral changes, low-dose atropine, special lenses.
Right, all the things we're using for school-aged kids.
Exactly. But the problem is, most of the interventions have been tested in kids aged, say, 6 to 16, with that more conventional progressive myopia. This group, infants and young children with high, often secondary myopia, has largely been excluded from those trials.
So we lack the evidence for them specifically.
Precisely. We have a significant lack of evidence regarding efficacy and even safety sometimes in these specific cases. And remember the heterogeneity we talked about earlier.
Yeah, over 400 conditions linked to myopia.
Exactly.
Yeah.
The underlying biology can be vastly different. So how these eyes might respond to standard myopia-controlled treatments, it's likely to be highly variable. Take MOP, for instance. We said it's often not primarily axial. So using treatments designed to slow axial growth might not make sense unless you actually document excessive axial elongation. And the paper advises caution with high concentration atropine in very young infants anyway.
What about the syndromic forms like Stickler? Does the myopia always progress rapidly?
Not necessarily. In many syndromic types, the myopia might be lenticular or corneal, or progression might actually be quite minimal after it first appears. The article mentions Stickler syndrome and CSNB as examples where progression is often limited. So the key message is, Always confirm that axial elongation is actually happening faster than normal growth before you jump to interventions.
And potential side effects need extra consideration, too.
Definitely. Think about photophobia in a child with a cone dystrophy. They might not tolerate the mydriasis from atropine at all. Or cardiac considerations in Marfan syndrome. You'd want to be very careful with atropine if it could affect heart rate.
So it really boils down to a highly individualized approach.
Absolutely. A case-by-case assessment is paramount. Intervention should really only be considered if you see clear evidence of progression, if the axial length is growing faster than expected for their age, and if you don't anticipate adverse interactions with their underlying condition.
What can we recommend generally?
The study does suggest advising increased outdoor activities. That seems like a safe, low-risk intervention for essentially all children with myopia. But for specific treatments, because clinical trials are just impractical for these rare, diverse conditions, the path forward might be pooling data in disease registries to build evidence over time.
It sounds like managing these cases requires a truly clear-eyed and careful approach, constantly weighing the risks and benefits against that specific diagnostic picture.
Thinking longer term now, we know high myopia carries significant risks later in life. Pathologic myopia.
Right, things like myopic maculopathy, staphylomas.
Exactly. Myopic traction maculopathy, too. The article notes these are rare before age 50, but the risk increases rapidly after 60. Confirms observations going way back.
Are there any early signs we can look for in these kids? Biomarkers.
Researchers are definitely looking. The study mentions that parapapillary diffuse choroidal atrophy, if seen in children with high axial myopia, might be an early indicator for pathologic changes and visual impairment later on. And interestingly, posterior staphylomas, which we used to think of as developing much later, have actually been found in highly myopic kids as young as 6 to 19 years old.
Wow, that early.
Yeah, it challenges some older assumptions about when these structural changes begin.
And the retinal detachment risk, you mentioned that earlier with syndromes like Stippler.
Yes, while RD is rare in childhood overall, the risk is definitely increased in some of these syndromic forms. Stickler, Marshall, Knobloch are mentioned. And often it's the vitreous abnormalities that are the main driver, meaning RD can happen even in Stickler patients who aren't that myopic.
Hmm.
And another important point, if a child does unfortunately develop an RD, having myopia greater than negative 10.0D can actually reduce the success rate of the surgical repair.
So bringing this all together, what's the core message we should take away from this deep dive? What's the bottom line for clinicians?
I think the highest priority, unquestionably, after you diagnose high myopia in a young child, is to determine if there's an associated medical diagnosis, something that might be even more important for the child's overall systemic health.
And that often requires teamwork.
Absolutely. A multidisciplinary approach is often critical, working with clinical geneticists, pediatricians, maybe other specialists, depending on the findings.
And regarding myopia control.
Remember that critical lack of evidence in these rare, heterogeneous secondary forms of myopia. If interventions are considered, close monitoring of both refraction and axial length is essential. Don't just assume it's working or necessary.
So it's about a holistic view.
Exactly. It's about preserving their vision for the long run, understanding the potential systemic connections that often come into view, and not just focusing on what meets the eye today.
What an incredibly important and complex area. This has been a fantastic deep dive. We hope this is giving you, our listeners, a clearer lens through which to see and manage high myopia in your youngest patients. Hopefully, you feel better equipped now to potentially make a truly life-changing diagnosis for them. We covered a lot of ground. For those who want to delve deeper into the specifics, remember, a link to the full IMI Journal article is right there in the deep dive description. And if you found this discussion valuable, please do follow the deep dive wherever you get your audio content. If you really liked what you heard today, we'd be incredibly grateful if you could take a moment to leave us a 5-star rating. It genuinely helps us reach more eye doctors like you. So here's a final thought to leave you with. As you approach your next young patient presenting with high myopia, what new insights, what deeper questions will you bring to uncovering their eye secrets now that you've had this deep dive? Farewell.